So the current guidelines and even guidelines that came before the CDC guidelines have given practitioners a lot of advice, some contentious, as to what to do with initiation of new patients and how to manage them going forward. But a population of patients that have really been missed and their clinicians that take care of them are those inherited patients who came to find themselves on opioids with good intentions, with our best available advice at the time, and now are often well in excess of what the guidelines are recommending. There's very little in the way of guidance offered from the CDC as to what to do with that population. And I really think that that's the population that, if we don't handle it well, are going to be the next population of people in trouble on the streets with prescription drugs and non-prescription drugs.
If we look at the journey of pain, we have to look at it in the following way. In the 1980s, there was a paper published by Porter and Jick that was one paragraph. And that paper took off and was cited over 900 times up to May of this year, of that it was safe to use opioids for the treatment of pain, and addiction would not happen unless there was a history of addiction. In other words, pain almost protected you from the disease of addiction. And from that became the fifth vital sign that we're all familiar with, the decade of pain control and pain research. And now what do we name this decade that we're in? Do we name it the decade of fear of opioid pain management? Do we name it the decade of morphine milligrams equivalence? Or do we name it regulation over education? Doug and I have discussed this, and we feel where the boat was missed, there wasn't a decade of pain education and pain and addiction medicine before this all began.
Well, I think we need to remember that everyone, not just pain doctors, but everyone needs to have an interest in addiction medicine and substance misuse, because it's not an uncommon occurrence in primary care and specialty care. And when handled well, it's an opportunity. When handled poorly, it's at best frustrating and in some cases catastrophic for both parties concerned. So the idea of every pain doctor needs to be a talented amateur in addiction medicine is essentially to say, recognize that there is risk. In fact, I often say jokingly that if you got a pulse, you've got a risk. The real question is, what's that risk? Is it low? Is it medium, or is it high? And more importantly, from the patient's perspective, how can that risk best be managed? And I think that's why programs that are offered here at PAINWeek over the last 10 years have been so important to help keep that balance point. Pendulum swings between opiophobia and opiophilia, and neither of those are credible places to be. However, the midpoint is where we need to aim for and try to maintain if we're going to manage pain effectively in the next few years.
I don't think that you could do pain management without knowing addiction medicine, because in my years, and I've done this over 2 decades, most of the questions are addiction questions. What do I do if? What do I do if I find this? What if I have an unexpected positive urine? What if I have an unexpected negative urine? What do I do in this area? The patient comes to me and does this. They're all in the area of addiction, and that's risk management is knowing addiction medicine.
But you know, I think one of the mistakes that we've made in our literature and our research has been to focus on this nebulous concept of iatrogenic addiction, doctors creating addicts out of otherwise normal people. There's a lot of abnormal behavior that occurs that would never reach the level of a diagnosis of a substance use disorder, and yet these are problematic behaviors. People are running out of medications early. People are asking for specific medications and combinations that are challenging for clinicians. It's clearly much of this behavior is abnormal. The real challenge is figuring out what the heck it means. So I think if we acknowledge our limitations, recognize that we don't know nearly as much as we hope to know, and in some cases need to know, then we can approach this, I think, a bit more humanistically. Pain management is unique in terms of identifying addiction, in that the medications that are being used are legitimately prescribed for a lawful medical condition. It's easy to identify cocaine addiction. It's easy to identify methamphetamine addiction because you're not recommending the odd line of cocaine for a sore back. But when the drug that is being used, and perhaps being used problematically, is a drug that has a legitimate and lawful indication for use in that patient population, identifying addiction is much, much more of a challenge. And I'm not sure it's all that useful to dichotomize these people into either pain patients or addictions patients. It's much more, as Howard and I said in a paper a number of years ago, it's much more likely to be a continuum in some of these patients. And if we approach it from that way, with education, structure, and supportive therapy, we'll probably do much better.
I think primary care is in a difficult position in our country, secondary to our dysfunctional insurance system. There is no way in hell that you could evaluate a person and prescribe a controlled substance and meeting that person for the first time. Very difficult. If we say that the disease of addiction, and notice I said the disease of addiction, not the moral failing of addiction, is present approximately in 8% of the population, excluding nicotine, which is about 19%. Again, back to my original point, why don't we have education basically in medical school, internship, residency, fellowships in this area? We don't do it, and therefore we have a buildup of this problem.
Well, you know, one of the advantages in the primary care paradigm is that primary care is about knowing enough about everything to be safe and to be effective. And when the limits are tested, when patient problems exceed the capacity of the primary care doc, they need to know how to pick up the phone, how to make referrals, how to mobilize resources that generally have more experience and more capabilities to deal with the more challenging patients. And then in an ideal circumstance, they can then come back once stabilized or at least assessed. The challenge, as Howard says, is management of time. In a typical primary care doctor's week, 40 hours could be taken up in preventative medicine. Now, that for most people would be considered a fairly long week, a 40-hour week, and yet that doesn't even include chronic pain, chronic disease conditions like diabetes, and acute injuries and fractures. So it's a challenge, but the advantage to primary care is they typically develop a level of intimacy, both in terms of family and individual patient, that lends itself to opening dialogues up that would be difficult for a specialist to advance in a short period of time of a 2-hour or 1.5 hour consultation. So I think primary care is the looking forward way to solve this problem.